Good morning, everyone. Thank you so much for joining us. We are excited for this pharmacy workshop. And I am Jonathan Grant. I'm the adult clinic CF pharmacist for Johns Hopkins. And my co-chair today is Dr. Cameron McKenzie, and I'll let her introduce herself.
Hey everyone, I'm Cameron McKenzie. I am one of the pediatric pharmacists at UNC in Chapel Hill, North Carolina. And Jonathan and I are glad everyone could join us today.
Yes, we are so happy that you are here and able to join us virtually. We are longing for the time that we can be back in person again. And there's just been so much change, so much that's been happening and going on. And in this session, we're going to be focusing on CF pharmacotherapy issues that are facing practitioners today. As one thing that I've been saying in the recent year and a half has been since Tricopter has been approved, and with the pandemic, it's been kind of like the wild, wild west. I think that's the best way of describing it, where patients are doing their own things and we're seeing, wacky things and weird things, and the literature has not been able to keep up with everything as fast as things have been happening because of this perfect storm that we have been in. So we are really excited, and we have 5 amazing abstracts that we're going to talk about today that will give us some insights into our practices and what is happening, and hopefully spark some really, really good discussion. So we are looking for you to be involved and for you guys to send us your questions. And I really hope that you learn something and that we take something back to our centers, and that will benefit our patients. So I'm gonna stop running my mouth and introduce our first speaker for today, Dr. Jeffrey Zobel. He has 15 years of experience at the CF Center in Salt Lake City, Utah. He works at the Intermountain Primary Children's Hospital and the Primary Children's CF Center in Salt Lake City, Utah. And you all know Jeff. He's amazing. He's a mentor of mine, and it is my pleasure to introduce him. And he'll be going over beyond PFTs, elexacaftor, tezacaftor, ivacaftor outcomes in a pediatric CF center. So I'm going to turn it over to Dr. Zobel.
Good morning. My name is Dr. Jeffrey Zobel, and I am an advanced clinical pharmacist at the Primary Children's Cystic Fibrosis Center in Salt Lake City, Utah. And it's my pleasure to present in this workshop's 26. Our topic, the title of our presentation and our poster is Beyond Pulmonary Function Testing, elexacaftor, tezacaftor, ivacaftor outcomes in a pediatric CF center. And I have nothing to disclose. So the background of our presentation is elexacaftor, tezacaftor, ivacaftor, ETI, which I'll refer to the remaining of the presentation, was FDA approved in October of 2019 for patients aged 12 and above, and recently has now been approved for down to age 6. The benefits have been demonstrated by ETI in multiple pivotal clinical trials, ones by Middleton and colleagues and Hagerman and colleagues, as well as open label extension studies. One that's recently been published by Greasing colleagues in 2021. Each of these showed improvement in lung function, decrease in pulmonary exacerbations, improvement body mass index in all of the patients when either compared versus placebo or comparative to tezacaftor, ivacaftor. Our study design, it was a retrospective chart review that we looked at from October 1st, 2018 to December 31st, 2020. And the reason we did this is so we could do 1 year prior to the approval of elexacaftor ETI and the 1 year post ETI approval. This study was IRB approved. The patients who were included in this study were ages less than 18, were diagnosed with cystic fibrosis, and were prescribed ETI during the study period. Our outcome variables, we looked at a 365-day pre-post ETI initiation. And the reason we did this is so the patients would serve as their own controls for each of the outcome variables. We used this so we could control for various factors. And one of the limitations, one you could look at was during COVID-19 pandemic that the second half of our study was done, but as they serve for their own controls, that helps control for that COVID-19 pandemic issues. The main outcomes that we looked at were the number of outpatient, inpatient antibiotic events, body mass index, and adherence rate using the mean medication possession ratio, or MPR, through looking at pharmacy fill data for our patients. The statistical analyses that were used in this study were paired t-tests for our patients in a pre-post fashion with the parametric variables, and then any non-parametric were used, Mann-Whitney U tests, to determine the pre-post fashion. When we look at the results, we had 70 patients included in our study, the median age of 15 years with a range of 12 to 18. Almost 60% of the patients in the study were female. Over 60% were homozygote delta 508, with the remaining having one copy of the F508del mutation. We also looked at previous CFTR modulator status. So majority of the patients were on a CFTR modulator, either ivacaftor, lumacaftor, ivacaftor, or tezacaftor, ivacaftor, and the remaining roughly 40% of the patients were only had one copy of delta 508, so they did not qualify for a previous CFTR modulator during this time. And almost 80% of the patients had commercial medication insurance, which you could look at, could help, help with barriers and other things as we looked at that stratification. And that's very similar to our center population. We have about 70–80% of our patients have commercial insurance, and the other 20 to 30% have a state-funded health plan. When we looked at the individual variables in the pre-post ETI initiation, well, first area was the outpatient antibiotic events. And so we looked at each of the modulators separately and then the total. As you can see, patients who are on ivacaftor, which is considered a highly effective modulator, there were 12 outpatient antibiotics that were prescribed in the year prior to starting ETI, and then none in the year after, as well as lumacaftor, ivacaftor, and tezacaftor, ivacaftor. You can see large declines. They were all statistically significant with in all of the modulator areas. And then when you looked at patients who were not on a previous modulator, there was also a statistically significant decline in the number of antibiotics that were prescribed on the outpatient side. So the total, there were 189 antibiotics that were prescribed for our 70 patients in the pre-ETI group, but only 28 in the post-ETI initiation group. Well, that was statistically significant. When we looked at inpatient antibiotic events, so these are admissions to the hospital to receive intravenous antibiotic therapy. And when we looked at the stratifications, ivacaftor, there was only one, so there was no way to do statistics on that because the numbers were so small. With lumacaftor, ivacaftor, also the numbers were too small, so it was not significant at that point. However, with tezacaftor and patients, ivacaftor and the patients were not on any previous CFTR modulator, there was a statistically significant decline in the pre-post group of admissions. And when you look at the total, there were 65 inpatient antibiotic events in the pre-ETI group, but only 3 in the post-ETI group. When we looked at those 3 further, we found that 2 of them actually had been admitted to receive IV antibiotics for Pseudomonas aeruginosa eradication. When their lung functions were looked at, they're probably not having exacerbation, but part of our protocols, we do admit for patients for Pseudomonas aeruginosa eradication. So 2 of those patients were admitted. And so, but it was still significant when you look at the decline in the pre-post fashion of inpatient antibiotic events. When we look at body mass index, you can see patients who were on a modulator previously and not on a modulator previously, they both had a 2% improvement in body mass index, and then the total also showed a very similar fashion of almost a 2% improvement in body mass index, which was statistically significant as well. The last area we looked at was adherence to mucolytic therapy utilizing medication physician ratio, which is an objective measure of adherence. And we looked at the mucolytic therapy of nebulized hypertonic saline and Dornase alpha. In the pre-group, we found that because 80% is considered the cutoff of adherent patient, and you can see both in the hypertonic saline and Dornase alpha groups, both of those were either approaching 80% or above 80% in terms of adherence in the pre-ETI therapy group. But in the post, they both showed a significant decline in adherence in the fill rate, which is very mirroring what we're seeing in our patient population. We are seeing patients who have been started on ETI therapy. They're not filling their nebulized mucolytic therapies as much as they were previously. And this it kind of showed us that this is something that's actually happening and it's real, but they're not having the same, do they really need it? Because there's a significant decline in exacerbations, and their improvement in body mass index does mirror that they're overall healthy. And our pulmonary function tests have also shown that as well. And so we feel that this is probably something that the simplified trial is going to show, that patients possibly do not need their mucolytic therapies as much as they were previously, because of the effectiveness of ETI as a highly effective modulator. So the conclusions of our study: ETI significantly benefits pediatric CF patients, both who are on prior modulator therapies and those who are not on a modulator, showing significant declines in inpatient antibiotic events, as well as significant improvement in body mass index, as well as in the inhaled mucolytic therapy. There were significant declines in the medication physician ratio. So we feel that this is something that could be further studied in other studies that are done, looking at adherence as well as mirroring what the pivotal trials showed for approval of ETI. I'd like to acknowledge the contributions of Madison Hill, Amanda Grady, and Rachel Belcher, who are pharmacy residents, who helped me with this project of data collection and statistical analysis last year, as well as the CF providers at the Primary Children's Cystic Fibrosis Center, Jennifer Stewart, Jennifer Hamilton, Kristen Mill, and Fadias, for further continued support. Thank you. And during the live Q&A, I'll answer any questions that you have. Thank you.
All right, welcome back, everyone. So we are in our first question and answer session. That was a fantastic presentation from Jeff. So let's go ahead and fire some questions. If you have not already, please send any of your questions in the chat there on your right into Slido so that we can ask Jeff. But I'm going to ask the first one here. So Jeff, regarding measuring adherence, did you consider calculating PDC to include maintenance airway clearance therapy in addition to elexacaftor, tezacaftor, and ivacaftor NPR?
No, we didn't do PDC at that time, so we just did NPR. But that's something that, as we wanted to present this first, so then we could get some ideas before we go to publication. But PDC is something we are looking at. Yes.
Okay, awesome. Another question has come in as well. For the NPR calculated for the patients, were these for both patients filling for both yours and outside specialty pharmacies, or just for patients filling at your specialty pharmacy?
It was all specialty pharmacies. We used we didn't look at our fill date from our specific pharmacy. We actually pulled through the insurance. We actually were able to pull that information through our EMR. And that's what we used to make it so it's standardized for all the patients to reduce any bias. So we just used one tool to do all the NPR calculation.
Okay, that's interesting. Did you look at the number of patients that had to stop elexacaftor, tezacaftor, ivacaftor because of side effects, and were they able to restart?
We didn't have any patients who actually stopped, so that's why the number was 0. So it was really easy. But since then, we've actually had a couple patients we have one patient we actually had to stop due to alcoholic pancreatitis and alcoholic liver disease. So we actually had to take one patient off, but she was not included in this study because she wasn't in the pre-post fashion.
Okay. I have another question for you as well. So there's a question in the chat that that the adherence numbers post elexacaftor, tezacaftor, and ivacaftor seems really high compared to what was seen at their individual center. Do you have a sense of what the national adherence rates are?
The only studies that have been done are the ones that have been done previously. There was one by NASR, as well as the one done in chest in 2005 when the eye care study showing like a 57% adherence rate for pulmozyme for Dornis alpha. There's some studies have been done with the modulators, but we haven't done any studies since then. So the national rates were pre highly effective modulator therapy. So it would be hard to know exactly what it is now, but I would assume that these are actually even lower now because that was, several months ago. And patients, as we got more and more patients on it, less and less. We're putting more people on as needed hypertonic saline, and so this is. The difference between doing NPR and actual adherence is people may, even though they're filling it, they may not be using it. So that's a difficult thing because there's really no good way to measure adherence unless we go into their house and see how many boxes they have in their refrigerator. If we could do that, that'd be great. But using NPR as or PDC are some of the only ways objectively that we can measure adherence. But I would concur it's probably lower than these rates that we're seeing now.
Yeah, I would totally agree with you. I think that adherence, there's no way to really capture it, right? So we're doing like the best that we can with this, but you don't know unless you're actually seeing them actually use it and do it every day. So 100% right there.
Right.
Another question for you, Jeff. Since adherence dropped in both of the mucolytics that were pre and post, did any patients express a preference of one mucolytic therapy to use over the other?
That actually is a very interesting question. Most of our patients are preferring to do kind of as needed pulmozyme, which is very interesting. They're kind of wanting to do it, 3 days a week, a couple of days a week when they're sick. A lot of patients have elected to stop hypertonic saline because they don't like when it makes them cough because they have nothing to bring up. So I would say majority of our patients in the study, no one has said that, but I just anecdotally, and some of those patients are in this trial, just as they would say, look, I want to do pulmozyme as needed. We try to tell them do it every day because we don't know, because Simplify has not been published, but we're to negotiate and try to, if they're not doing it, at least get them to do it a few days a week. And we've had some patients who have actually started doing it at least a couple of days a week just to keep it moving. Keep their mucus moving, because we've seen sometimes if they don't do it, their PFTs kind of decline a little bit. And they actually presented some information a couple of days ago in one of the symposiums I was in. They actually see a decline still in Tricopter patients over time. The maintenance is still may start to come down. You see that with ivacaftor as well. So there may still be a need for for kind of as needed Dornase or hypertonic saline, but we still don't know anything because Simplify is still a year out from being published.
Gotcha. Thank you. Do you think that COVID had an impact on the number of antibiotics prescribed?
Yeah, that's something that has been brought up multiple times when doing this. So that's why we did the pre-post fashion. Most of these patients were really sick prior to being on, ETI. There could be some sort of COVID thing in there because people were isolated, people weren't going out. So respiratory viruses were all thrown to the wind. Now we're seeing RSV seasons that are different than they should have been. And I'm sure there is some effect, but probably the only way to do this is probably do like a case control fashion. But we did the best we could with the pre-post. And if anyone has any ideas on how to go back and look at something during a pandemic when everyone was affected by it, because our rates of decline, we were still seeing patients in clinic and we were doing home monitoring PFTs. So we were still seeing them, but they were not getting sick. And so that decline in the decline started before COVID hit. So we're starting to see our admissions in January and February were actually off, and we see the graph going down. We were already seeing the decline in emissions prior to COVID happening. So we feel this is more the Tricopter effect, not the COVID effect of being isolated. So I think majority of this, you can actually show that mirroring the randomized controlled trial of a reduction in exacerbations, this is more the ETI effect as opposed to the COVID isolation effect.
All right, and then one last one. Were you able to review your data to determine if there was a difference in outcomes between patients with decreased NPR versus those who continue to fill?
The numbers were so small to try on that. It became almost, because when you look at the numbers of patients who are actually getting exacerbations and getting with only 3, the statistics were just almost impossible to do on the post group. So if you try to do by NPR, it didn't really measure out because both groups had such a dramatic effect in whether they're filling or not. So that would be something we could look at, but you're looking at such small numbers on the post side that doing any statistical analysis probably would have, it'd be very difficult to do, because even the one person who was admitted was still doing their stuff. So, it didn't really, they got sick. So it would be very difficult to do, but we could do it go back and look at it. And that's what we're doing. We're looking at for publication. So these are the things that we were looking at. We need to analyze. So make sure we get all that information and we put this together for publication.
Okay. Yeah. Thank you, Jeff. I feel like it was definitely that perfect storm type of environment where I do think that most of this is obviously from elexacaftor, tezacaftor, ivacaftor, but at the same time, I do question and wonder how much was the fact that we were quarantined at home for a year and not out as much, and all of the increased infection control guidelines and stuff. How much is that also playing a factor in this? So
could there have been one thing we could look as who got COVID during that time and see what they responded to their symptoms. But what we have seen is patients who actually got COVID who are on ETI breeze through it much easier than their parents or who got it, or or siblings who didn't have ETI. So, I mean, that's something we could look at as the patients who ended up testing positive for COVID. Those numbers are small, but if they did see if they did get sick and if we did prescribe an antibiotic, if I remember correctly, those numbers were almost zero, but we could go back and look at that just to include that information in there.
Okay. Well, thank you, Jeff. That was some invigorating and really great discussion that we had there. Thank you all for your questions. They were really great and on point. I do want to go ahead and transition over to our next session, which we are going to go with Tricopter, elexacaftor, tezacaftor, and ivacaftor intolerance, one center's experience. And this is from Dr. Kim Ehlert, who at the time of this publication was with the Minnesota Cystic Fibrosis Center with Fairview, but she has since moved and transitioned into a new role. But I'm really excited for this because we want to talk about some of the patients that were not able to tolerate elexacaftor, tezacaftor, and ivacaftor. So without further ado, let's watch our next video segment.
Hi, my name is Kim Ehlert. I'm a pharmacist from the Minnesota Cystic Fibrosis Center in Minneapolis, Minnesota. Title of my talk is Tricopter, elexacaftor, tezacaftor, ivacaftor intolerance, one center's experience. I have no relationships to disclose related to this presentation. For a little bit of background, as I'm sure we're all very well aware by now, elexacaftor, tezacaftor, ivacaftor, or ETI, is a highly effective CFTR modulator therapy that has been shown to significantly improve lung function and CFQR respiratory domain scores. When ETI was first approved by the FDA in the United States in 2019, patients at our center were very excited, very enthusiastic, and eager to get started on this promising new therapy. However, what we noticed over time is that despite some clinical benefits, some of our patients were stopping ETI due to adverse effects. So looking at the original phase 3 clinical trials for the approval of ETI, we wondered what the discontinuation rate was in those studies. So in the first trial of patients that were heterozygous for the F508del mutation, in this study, there were only 2 patients, or 1% of the study population in the ETI group, that discontinued the trial regimen due to adverse events. There was 1 patient that experienced a rash and 1 patient with portal hypertension that developed. However, this individual did have pre-existing cirrhosis. Not surprisingly, there were no patients in the placebo group that discontinued the trial regimen due to adverse effects. Of note, this particular trial lasted for 24 weeks. The other pivotal trial was conducted in patients homozygous for the F508del mutation. And in this study, there were no adverse effects that led to discontinuation of trial regimen, either in the treatment group or in the placebo group. However, this trial was considerably shorter and lasted only for 4 weeks. So following these 2 studies, there was an open label extension study that included 506 patients that were rolled over from both the homozygous and the heterozygous group into this open label extension study. Earlier this year, there was an interim analysis published of the data after this 24-week extension. So this did give us a little bit of additional data on some of the longer-term effects of ETI. In this analysis, it was noted that 7 patients, or 1.4%, did have adverse effects that led to discontinuation of ETI. So this was a slightly higher discontinuation rate than what was noted in the first 2 studies. Of those 7 patients, 4 of them stopped ETI due to liver events. 1 person stopped related to depression. 1 person experienced a rash, and 1 person experienced both tinnitus and contusion that led to ETI discontinuation. So based on what we were observing in our own patient population, we felt that it seemed that there was a higher rate of discontinuation of ETI in our patients. So we decided to conduct this study, which was a retrospective observational study. This was done using medical chart review from November 2019 through March of 2021. Our primary objective was to determine the rate of discontinuation of ETI due to adverse effects. But it should be noted, this is people that completely permanently discontinued ETI. It did not include any patients who temporarily stopped or had a therapy interruption and then later resumed. So these were people that permanently discontinued ETI. And it also only included patients that stopped ETI due to adverse effects. We did have some patients that stopped it for other reasons, such as having a lung transplant, or some patients that stopped it due to pregnancy. So this analysis only considered patients that stopped because of adverse effects. Our secondary objectives were to examine the reason that ETI was stopped, to evaluate the genotype status, whether homozygous or heterozygous for F508del, to look at prior modulator therapy, and to evaluate the duration of ETI treatment prior to discontinuation. During this time, we had a total of 332 patients at the Minnesota Cystic Fibrosis Center, age 12 and older, that were initiated on ETI during the observation period. What we found was that ETI was permanently discontinued by 16 patients, or 5% of them, due to a total of 28 adverse effects. Should be noted that there were some patients that experienced more than one adverse effect that was attributed to ETI. The next thing we did is examined the different reasons for discontinuation. As I mentioned, there were 28 different adverse effects that were reported, and we categorized them based on some kind of broad generalizations. The most common reason that patients stopped ETI was related to GI side effects. We had 8 patients that discontinued ETI due to things such as nausea, bloating, and diarrhea. The second most common reason was changes to mental health. We had 6 patients that stopped it either due to new or worsening of pre-existing depression, anxiety, insomnia, or some combination thereof. We had 5 patients that stopped for what we considered constitutional symptoms, such as joint pain, myalgia, and fatigue. And then we had 3 patients that discontinued due to respiratory side effects, such as shortness of breath, chest tightness, and wheezing. Less commonly, we had 2 patients that did stop due to tinnitus, 1 person who stopped because of weight gain, 1 person who discontinued due to some recurrent episodes of hypoglycemia, 1 person that experienced some hormonal type side effects, and 1 person that stopped due to rash. As far as prior modulator experience, half of the patients, so 8 of them, were naive to CFTR modulators prior to starting ETI. Of the remaining, 4 people had previously been on tezacaftor, ivacaftor, 2 had previously been on ivacaftor alone, And there were 2 people who had been eligible for other CFTR modulators but had not previously been prescribed a modulator prior to starting ETI. As far as the outcome, for 10 of the 16 patients, once they stopped ETI, they were no longer on any CFTR modulator therapy at all. The 4 people that had been previously on tezacaftor, ivacaftor resumed that therapy, and the 2 people that had been on ivacaftor also switched back to ivacaftor. The time to discontinuation was interesting. This graph shows for all of the 16 patients the time that they had been on ETI prior to stopping therapy. Across all 16 patients, the average time was 27 weeks. However, there was a very wide variation of anywhere from 2 to 62 weeks. So we did have some people that were on ETI for a very short time prior to stopping it. And then there were also people that started to experience some of these adverse effects later on, either 6 months or a year into being on therapy, and stopped it much later. A few other interesting results that we found. 14 of the 16 patients were heterozygous for F508del. Only 4%, or a quarter of the patients, did try a lower dose of ETI prior to stopping the medication. And of all 28 different adverse effects, 25 of them resolved completely after ETI discontinuation. The 1 person who experienced some hormonal side effects did have partial resolution, so her symptoms improved after ETI was stopped, but did not completely resolve. And then 1 person who stopped due to weight gain, that did not improve after stopping ETI. And 1 person continued to have some GI symptoms following ETI discontinuation. So what we concluded is that the discontinuation of ETI due to adverse effects occurred more frequently in this single center observational study compared to phase 3 clinical trials for ETI. Some of this can be explained, such as differences in patient populations between clinical study patients and our real world experience. Obviously, due to some inclusion and exclusion criteria with the trials, you'll get some slightly different patient populations. And the timeline may also be significant. As we noted, there were several discontinuations that occurred much later after therapy was started, and to date, our clinical trials have not been extended long enough to pick up some of those types of scenarios. A few other thoughts regarding our findings. One is that better management of adverse events could help to prevent ETI discontinuation. This would be particularly beneficial for those patients that are not eligible for any other modulator therapy. It would be really helpful to be able to work with them to help manage those side effects so that they don't have to permanently discontinue ETI. I think part of that can be conducted by doing a lot of good education up front, letting people know what things that might occur. And I think really the take-home message is that we think that we can work with patients to really manage those medications so that the only alternative isn't just stopping ETI. Another thing that would be helpful is better understanding of the effects of CFTR modulation, particularly the effects beyond the lungs. It is difficult sometimes to try to manage some of these side effects when we don't truly understand the underlying mechanism behind them or why patients are experiencing some of the things that they've been reporting to us. Finally, it would also be very helpful to further explore some alternative dosing regimens that could hopefully improve tolerability of ETI without significantly compromising the efficacy. And I know there's been a lot of discussion around different dosing regimens and some off-label recommendations, such as switching the morning and the evening doses, or reducing the dose to just the 2 orange pills or 1 orange and 1 blue pill each day. There's a lot of different ways that could be managed, but it would be helpful to further explore some of those options. So again, we can hopefully better manage some of these side effects and allow our patients to continue on this really successful therapy. I'd like to invite you to view our poster number 253. And I would also like to thank my co-authors, Sarah Shackley, PharmD, and Jordan Dennis, MD, also from the Minnesota Cystic Fibrosis Center. Thank you.
All right, and we are back. That was a really exciting session. Thank you, Kim, for your poster and for that abstract. And if you have additional questions in the audience, please type those in the Slido so that we can go ahead and ask. And I've got a few already lined up for you, Kim. So
all right, bring it on.
Let's go. The first one is, can you provide details on the patient with the hormonal side effects?
Yeah, so this was really interesting. This was actually a post-menopausal woman who had been previously on tezacaftor, ivacaftor, and switched to triple therapy. And after being on triple therapy for several weeks, she actually reported that she felt like she was not postmenopausal anymore. She started experiencing some menstrual bleeding again when she hadn't had a period for a few years. And she experienced almost daily hot flashes that went away after starting triple therapy. So she said it was just like her hormones completely switched back to pre-menopausal state, which was really unusual. So she actually followed up with her OB and had some testing done. Everything seemed okay. So for her, it was easy enough to manage because she had been on the tezacaftor, ivacaftor previously. So she just switched back. And most of the things that she was experiencing did kind of resume to her pre-triple therapy state. So the menstrual bleeding stopped. Hot flashes, unfortunately for her, did resume, but it was a really very unusual situation.
Yeah, sounds like it. Sounds very, very interesting.
Yes,
for sure. Okay, another one for you. For patients who tried a reduced or altered dosing strategies, did it seem to help their symptoms at all, even if they ultimately had to discontinue?
Yeah, I would say, in general, the dose reductions helped a little bit, but again, these are patients that ultimately did discontinue. So we did have other patients that had some side effects that we were able to manage with dose reductions that were able to stay on it. But for this particular group, some of them had a little bit of relief, but not enough to where they felt comfortable staying on the medication. For people that were eligible for other modulators, it was easy enough to just switch them back to what they had been on before. But what was really surprising to me was the number of people who wanted to just completely stop their triple therapy altogether because they didn't have any other options. So I do feel like with additional time and experience, we got better at kind of coming up with some of those alternative dosing strategies. But some of those early patients that had those really bad side effects early on, we didn't have a lot of experience with that. So I think more of those people ended up just stopping it.
Yeah. And then a follow-up with that, or in that same realm, are you all well, you left now, but as a center, were you guys thinking about retrialing ETI on these patients that have stopped at some point?
Yeah, I mean, we certainly encouraged it. A lot of patients really, though, were, once they made up their minds to stop it. There was kind of no going back. And I think that that was probably the most common in the patients that had changes to their mental health. And a lot of people, kind of express it as, I feel like I have to make a choice between my physical health and my mental health. Like, I know that this medication is improving, my lung function and helping my physical health, but I'm depressed, I'm anxious, I can't sleep, I feel terrible. And, that's just such an awful choice for anybody to have to make. And ultimately, most of those people just felt like it doesn't do me any good to feel better physically if mentally I'm really struggling. And the other thing with that too is, of course, all of this was happening in the setting of COVID-19 and the pandemic. And, my first thought was, well, I think people in general are feeling more depressed, more anxious right now. So that was one thing that I did kind of explore with patients that were reporting those changes is, do you think this could be related to the fact that, you've been in quarantine, or a lot of our patients, being high risk, were very careful and did not go out, didn't see people. And all of the patients really felt strongly that, yeah, I get that. And sure, that has affected me, but they really felt like the changes they were experiencing with their mental health were somehow tied to the medication.
Gotcha. Okay. Well, thank you for that. And that would actually segue us into our next question, actually. Did you all have a process for assessing mental health and determining whether mental health issues were likely ETI related versus not?
Right. And we didn't have a formal process, outside of kind of our usual assessments that our CF social workers do. To be quite honest, we were kind of caught off guard because, again, this was not something that was a known or reported side effect from the medication. So when we started hearing this from more and more people, we were really kind of surprised and weren't probably in the best position to deal with it right away until it became kind of a more common theme. And now that we have been more aware of it, we do ask people, I think more specifically, aside from just the usual assessments for depression and anxiety, but we do specifically do a better job now of asking patients if they've noticed any changes in their mental health since starting the medication. And now with the approval of the 6 to 12-year-olds, we also kind of have a better sense with that group now initiating therapy to ask and check in on those changes for them as well.
Okay. Another one for you. Were you able to tell which side effect categories led to earlier versus later discontinuation in therapy, and if there was a trend?
The trend that we noticed, and again, this is relatively, it's only 16 patients, but in general, I would say the GI symptoms were the early discontinuations, and then the mental health were the later discontinuations. So I would say that would be the one trend in general that we noticed.
Okay. And then another one as well. How would you describe how your team attempted to manage some of these side effects? Was this like a team approach? Was it a collaboration with the dietitians, the doctors, the pharmacists, all working together on the GI symptoms before they were discontinued? Or how did you guys try and manage these?
Right. Yeah. It's definitely, it takes a village, right? So we definitely did work together as a team. Our dietitians have been very involved with the patients that have experienced the GI side effects. And again, over time, we kind of learn tricks and things that we can recommend to patients to help manage those side effects. Because again, our main goal is to keep them on the therapy, even if it needs to be a lower dose, we feel like that's still better than nothing. And so I think just learning some of those common things and those themes, and then learning the management tricks. And our message to patients was, yes, you might experience some things, but we can manage it. We can work with you. We have some strategies. So we definitely got involved. Again, the dietitians with the GI side effects, social workers with some of the mental health things, trying to, set up patients with referrals to psychiatrists or psychologists. So we could help, again, kind of address some of those challenges.
All right, and then one last one. So in one of the categories was about the muscle or joint pain for multiple patients. I'm curious, how did you guys attempt to manage that? Or obviously it was the ETI was discontinued, but what was you guys' thought process? Because I still don't know, or I don't have the connection as to how the CFTR modulator connects with that.
Right. Yeah. I mean, some of the other things kind of made more sense, but some of these things that were reported were certainly, again, unexpected or unexplained. And, that was the conversation I had with a lot of patients too, is, I can't explain this. I don't know why. And it's really hard to manage if we don't understand what the kind of the underlying cause of some of these symptoms are. So that was certainly one that was a little bit more of a mystery, but I mean, people talked about just, significant fatigue, just these muscle aches, body aches that just didn't go away. So, again, it kind of comes down to that quality of life issue versus the health benefits of the medication. So I think the other thing that was really that patients just want to be heard too. A lot of times they'll come in and say, well, I've experienced this. And I think a lot of just from reading on like social media and things where patients share their experiences, a lot of them voice frustration that their symptoms were just dismissed, that, oh, that's not from the medication. And I think even if it's unlikely, patients still just want to be heard and want you to just listen to them and take it seriously and, work with them on some of these strategies and not just kind of automatically dismiss it. But, on the other side of that too, you can't blame everything on triple therapy either. But I think patients just appreciate, having their concerns being taken seriously and addressed by the team.
Yeah, I mean, I think it's definitely like a balancing act, right? Because everything is not necessarily Tricopter, but there's also a lot that we still don't know as well.
Exactly.
So I'm really looking forward to the upcoming research and what we can find out more and see if we do have a more scientific base that can help us explain some of what we're seeing in practice. So thank you so much, Kim. This was really insightful and really great. So thank you so much.
Thanks a lot.
We're going to transition over to our next video and speaker. We're going to look at the evaluation of the drug-drug interaction potential of clofazimine and ivacaftor using a physiologically based pharmacokinetic simulation approach. And this is from Dr. Eugen Holm from the University of Southern California, Department of Pharmacology and Pharmaceutical Sciences. So we will see you after the video.
Hi, this is Eugen Hong. I'm a PhD student in Dr. Berenger lab at the University of Southern California. This presentation is about evaluation of the drug-drug interaction potential of clofazimine and ivacaftor using a physiologically based pharmacokinetic simulation approach. And there are no relationships to disclose related to this presentation. Okay, so I want to first briefly introduce about non-tuberculosis Micromontreal and cystic fibrosis population. NTMs are increasingly being isolated from CF, and the most commonly identified species in CF are Mycobacterium avium complex and the Mycobacterium abscessus, which takes up around 40% of NTM infection in CF. Especially this abscessus is a pathogen of concern in CF due to its intrinsic resistance to antibiotics and its association with deterioration of lung function in CF. Indeed, a study of 432 CF patients published in 2016 found out that abscessus was associated with the worst impact on lung function. They investigated the impact of chronic infection by each CF pathogen on the rate of decline in FEV1, and the abscesses had the largest effect on the lung function. There is a treatment guideline for abscesses published by CFF and ECFS. The treatment requires a multi-drug regimen that includes several IV and oral drugs for over a prolonged period of time, creating the potential for significant drug-drug interactions with other chronic medications that CF patients take. Especially among these guideline-recommended antibiotics, clofazimine has conflicting information regarding its CYP3A modulating activity because several in vitro studies have reported that it is CYP3A4 inhibitor, but there is another report of its potential CYP3A4 induction activity. So there is a question about whether concomitant use of clofazimine with Tricopter, which is metabolized by CYP3A4, without dose adjustment is appropriate. So I will explain about this issue in the next slide. Okay, so here's the metabolic pathway of Tricopter components, elexacaftor, tezacaftor, and ivacaftor, which are also called ETI. All three components are metabolized by CYP3A enzyme, generating active metabolites, so these create potential for significant drug-drug interactions. Especially ivacaftor is the most sensitive CYP3A substrate among three components, as 95% of the drug is metabolized by CYP3A. Like I briefly mentioned in the previous slide, it is controversial whether concomitant use of clofazimine with ETI requires dose adjustment or not. The previous recommendation by Vertex was no dose adjustment is needed for ETI when it is being taken with clofazimine. However, it has been recently changed that there are insufficient data to classify clofazimine's CYP3A modulating activity, so more research is required. Therefore, in this study, I aimed to investigate the effect of clofazimine on the PK of ETI to determine potential dose adjustment of ETI components. Okay, so the hypothesis of this study is that clofazimine would cause drug interaction with ETI, requiring their dose adjustment. And I have two aims here. First one is to determine the potential drug-drug interaction between clofazimine and ETI, then to determine the appropriate dose of ETI when concomitantly used with clofazimine. So the first thing that I did was to measure the CYP3A4 modulating activities of clofazimine to classify the degree of CYP3A inhibition and induction. For that, I performed reciprocating IPA-based metabolism assay in HepaRG cell, which is the human hepatocyte-like cells that maintain metabolic characteristics of human hepatocyte. And the LIPA is selectively metabolized by CYP3A4, generating luminescent signal. So here I measured the impact of clofazimine on CYP3A4 activity related to other known strong, moderate, or weak inhibitor or inducer. For inhibition assays, cells were incubated with drugs and LIPA together to measure the competitive inhibition effect. And we could see that clofazimine significantly reduced the luminescent signal, which means that it inhibited CYP3A4 activities. The signal in clofazimine did not show significant differences with fluconazole, which is a moderate CYP3A inhibitor. So here we could determine that clofazimine can be classified as a moderate CYP3A inhibitor. For the induction test, cells were incubated with drugs for 48 hours to induce CYP3A enzyme. And this time, clofazimine only slightly increased the luminescence, and its magnitude was even less than lupinamide, which is the mild inducer. So here I could conclude that clofazimine's induction effect is negligible or just very mild. So based on this data, we proved our hypothesis that clofazimine would cause significant drug interactions with CYP3A4 substrate drugs by inhibiting their metabolism, since clofazimine's inhibition effect would be much larger than the induction effect. Okay, so next, to predict drug interactions of clofazimine with ETI components, we utilized PBPK simulation approach implemented with SimSip software. So with this flow chart, I want to first briefly introduce the steps that I took before going into the detailed data. First, for the model development of Tricopter, we utilized system components of healthy volunteers that contains physiological parameters of that population. This healthy volunteer is expected to be the most appropriate population for this study, since the PK of Tricopter in CF are not different with healthy volunteers. We also utilized the drug-dependent components, including physicochemical properties and ADME parameters acquired from clinical PK data or in vitro data. Then we verified this model using PK simulation. And here we determined whether simulated PK parameters such as AUC or Cmax match with the observed PK parameters of these components. And the next step is again model verification, but this time using drug-drug interaction data. Here we determined whether predicted interaction match with the clinically observed interaction data with other CYP3A inhibitors such as ketoconazole, fluconazole, or itraconazole. And then finally, we applied this model to simulate the interaction of these three components with clofazimine. We used clofazimine PK model that was previously published in 2018. And to this model, we added information on clofazimine's induction potential that we measured, and then we partially validated this model using drug-drug interaction data with betaquin. So this is the data table of ivacaftor that I used for its model development. We collected its physicochemical properties as well as absorption, distribution, and clearance parameters, which could be obtained from various sources, including regulatory documents or publications. And similarly, we also obtained data for elexacaftor and tezacaftor, mostly from NDA documents to construct their model. And we verified that all predicted PK parameters and drug interaction parameters were within the range of 0.7 to 1.1 of the observed parameters, which are within the range of acceptable model performances. For example, in the ivacaftor and fluconazole drug interaction, the predicted ratio of ivacaftor AUC was 2.99, which was close to our previously observed 2.95. So based on these data, we determined that developed models of ETI are adequate to evaluate the CYP3A4-derived drug interactions. So the next step is to perform simulations of interactions of ETI with clofazimine. For that, clofazimine model also has to be developed, but fortunately, there is clofazimine model published already in 2018. So this is the PBPK model parameters for clofazimine in the publication. And here it contains CYP3A4 inhibition potential, but not the induction parameters. So we additionally incorporated induction potential that we measured through the in vitro gene expression assay. And this clofazimine model was partially validated using observed drug interaction data with betaquin, which is another CYP3A4 substrate drug, where no drug interaction was observed. Utilizing this betaquin compound file that was obtained from SimSip members area, we simulated clofazimine's drug interaction with betaquin, and the predicted AUC ratio was 1.14, which corresponds to the observed data. So we first predicted drug interactions of clofazimine with ivacaftor, which is the most sensitive CYP3A4 substrate among Tricopter components. Since clofazimine's half-life is 25 days, it takes almost 130 days for clofazimine to get to its steady state. So we simulated standard dose of ivacaftor and clofazimine that are co-administered for 130 days to predict the drug interactions at the steady state. The PBPK simulation of steady-state ivacaftor with or without clofazimine resulted in the AUC ratio of ivacaftor as 2.54, and it was actually not significantly different from the predicted AUC ratio derived only by clofazimine's inhibition potential, which was 2.61. It suggests that its induction effect would be very mild, corresponding to our previous lipid metabolism assay, and therefore ivacaftor dose adjustment would be required due to this significant inhibition effect by clofazimine. Then we further simulated the drug interactions of all three components with clofazimine. For ivacaftor, the AUC ratio was 2.61, which means that clofazimine moderately inhibited ivacaftor metabolism. And the AUC ratio of tezacaftor and elexacaftor was 1.88 and 1.76 respectively, which corresponds to the weak inhibition. Then we determined the adjusted dose of Tricopter in case of concomitant use with clofazimine. Based on simulations, the dose of Tricopter needs to be decreased to 2 orange tablets and 1 blue tablet on alternate days. And the evening dose of ivacaftor don't need to be taken. And this decreased dose was consistent with Vertex recommendations for moderate inhibitor. This decreased dosing regimen of ETI provided similar steady-state PK parameters with the standard dosing regimen of ETI alone. That the AUC was from 87% to 138% compared with the standard regimen. Here, this decreased dose of Tricopter needs to be started after 10 days of co-administration with clofazimine, because clofazimine requires some time to accumulate towards steady state due to its long half-life. There's a few limitations of this study. As I mentioned earlier, there are active metabolites of ETI, and the active metabolites of elexacaftor and ivacaftor were not incorporated into this PBPK analysis due to the insufficient information to build a model. But I could include the active metabolite of tezacaftor, and the simulations of M1 tezacaftor show that with the decreased dose of tezacaftor with clofazimine, the M1 tezacaftor could achieve around 67% of its exposure with tezacaftor alone. To conclude, the PBPK simulation results suggest that clofazimine is a moderate inhibitor, leading to the clinically significant drug interaction with Tricopter, requiring the dose adjustment. And the clinical data might be needed to further validate the simulation result. Since the PBPK model that we employed could robustly predict PK parameters and drug interactions of ETI, it can be also used to evaluate and provide guidance on other potential drug interactions involving Tricopter for CF. I would like to thank Dr. Berenger, who is principal investigator and guided this whole research, and Dr. Lau, who is co-investigator. I also acknowledge funding from Cystic Fibrosis Foundation. And thank you all for listening to my presentation. Thank you.
Welcome back, everyone. That was a very enlightening presentation from Dr. Hong. I think I learned a lot from it. And if you haven't already, please go ahead and submit your questions in the Slido so we can have a very interactive and beneficial discussion. So Dr. Hong, I'm going to start with the first question. Is one that I have. I wanted to ask, so in the presentation, you had said that it's best to wait 10 days before initiating the reduced Tricopter dose. And I just wanted to ask kind of I guess the reasoning or the data behind it being 10 days.
That's actually very good question. So actually, in general case, we just start the adjusted dosing regimen right away once we start concomitant inhibitor therapy. But unlike the other drugs who get to the steady state pretty quickly, clofazimine requires very prolonged period of time to get to the steady state because of its prolonged half-life. So we simulated the drug interaction of clofazimine with ivacaftor first, because ivacaftor is the most sensitive CYP3A substrate among 3 components of ETI. And we found out that ivacaftor AUC ratio gradually increased until clofazimine level gets to the steady state level. And after 10 days of co-administration with clofazimine, ivacaftor AUC ratio gets to 1.5, so 50% higher than the standard regimen of ivacaftor alone. And when we started decreased dosing regimen at this point, ivacaftor AUC ratio gets close to 1.0 and never gets lower than 1.0. So we decided that this time point might be the most appropriate timing to start the decreased dosing regimen of Tricopter. So
Okay, very, very interesting. Thank you for that. So the first or the second question that we have here now is, how long after stopping clofazimine would you consider it appropriate to increase ETI dosing back to the full dose?
I see. So actually, we didn't simulate that part, like after ending the clofazimine, how long it takes to recover the Tricopter full dosing regimen. But based on similarly the simulation that we did for the first part of the co-administration, we also think that it might take some time that clofazimine is completely eliminated from the blood because of its long elimination half-life. So it might take some time from 1 to 2 weeks to recover the Tricopter dosing regimen to the standard dosing regimen. But to accurately predict that, we need more simulation for that part. I think that's a good point.
Okay, yeah, because I feel like it's got such a long half-life of 126 days. So like, I mean, that would be a really long time if we waited for the 3 to 5 half-lives to pass, as we normally would. But I mean, that's like a year if we did that. So
yeah. So actually, the half-life of clofazimine is 25 days, but to get to the steady state level, it requires 5 times of half-life. So it takes 130 days almost.
Gotcha. My bad there. I got that one off. So one more a question as well. And actually it's losing. Oh, so this was a personal question or comment here, but so I found it very interesting the fact that as your data showed that it's a mild CYP3A4 inhibitor as well as a negligible or very weak inducer. And so, I don't know, part of me theoretically wants to think or believe that, that induction property helps to make it from a moderate inhibitor to, more of a weak to moderate inhibitor. But I'm assuming, but based on what your simulation showed, that it appeared that it really is still a moderate inhibitor regardless of its induction. Is that right? Am I getting to the right conclusion?
Yes, you are very correct. So based on our in vitro data, clofazimine might moderately inhibit CYP3A4 metabolism, but at the same time, it just very weakly induce the CYP3A4 enzyme, which means that clofazimine can bind to the active site of CYP3A4 enzyme so that it competitively inhibits other like CYP3A4 substrate drugs metabolism. But at the same time, it can increase the CYP3A4 amount itself so that it can increase the CYP3A4 mediated metabolism, but its magnitude was just very mild or negligible. So we incorporated those parameters together and then did PBPK simulation. But still, since its induction effect is very mild, it still causes moderate inhibition to the Tricopter component.
Okay. And then I have another question that has come in. This is very, very helpful and important data. Do you know if Vertex will update their recommendations to officially include clofazimine as a moderate inhibitor?
Okay, so based on our in vitro study and in silico PBPK simulation approach, we concluded that clofazimine might be classified as moderate inhibitor. So it requires dosing regimen corresponds to the moderate inhibitor. It would be helpful if we have clinical data to validate this result, so that it can be officially included as a moderate inhibitor. But like I said, clofazimine, due to its long half-life, it requires very long time period to get to the steady state. So it is pretty challenged to do the clinical study of clofazimine. So to indirectly validate this result in the clinical setting, we are aiming to find patient who has been taking clofazimine for more than 130 days. So the level of clofazimine in those patients is expected to be already get to the steady state. So by comparing the ETI component exposure in those patients versus the ETI level in patients who are not taking clofazimine. So by comparing the Tricopter level in those two different patient populations, we can validate our result that clofazimine actually causes moderate inhibition of Tricopter components. Then we can further confirm this in silico simulation result.
Gotcha. Okay. And the next question is, can you comment on the ETI dose adjustments for concurrent fluconazole given daily versus once weekly?
So for my understanding, since fluconazole is classified as a moderate inhibitor, based on current recommendation by Vertex, it requires 2 orange tablets and 1 blue tablet on alternate days. So I'm not sure if I understand correctly about once weekly.
Yeah, so I think what they're trying to ask is if the patient is taking fluconazole once a day, right? So then that would apply. But if they are taking the fluconazole kind of once a week or on a less frequent basis, what do you think about the dose adjustment in that setting?
Got it. Okay. So since current dosing guideline is based on the fluconazole given daily, standard regimen, so then it can act as a moderate inhibitor. So it requires dose adjustment. But I am not sure whether fluconazole given once weekly still cause moderate inhibition of Tricopter. My guess is that the moderate inhibition might be graded down to weak inhibition, which doesn't require any dose adjustment of Tricopter. But it's just my guess. But I guess we might need further simulation or clinical results to see that result. Okay.
All right. Well, thank you so much, Dr. Hong. I think that we have gone through all of our questions. That was very insightful, and hopefully we can find enough patients that have been on clofazimine for 130 days, and we can do some clinical follow-up as well. So thank you so much for all your time and insight.
Thank you.
Okay. And so for our next abstract that we're going to review, it is elexacaftor, tezacaftor, and ivacaftor exposure to infants born to mothers taking ETI during and after pregnancy. And this will be presented by Dr. Aaron Trimble. Dr. Trimble grew up near Anchorage, Alaska, and then headed across the country, literally, to attend college in Virginia. After finishing his medical school and residency at the University of Virginia, he moved to Chapel Hill, North Carolina for fellowship with a particular interest in cystic fibrosis. Afterwards, Dr. Trimble spent an additional year at UNC dedicated to CF clinical research and care. His desire to move back to the Pacific Northwest brought him to the Oregon Health and Science University, OHSU, in August of 2018. And I'm excited to learn more about this because this is a topic that we're seeing a lot with all of our Tricopter babies in the baby boom. So we will see you after the video, and please send us your questions in the chat.
Good afternoon or morning, and greetings from Portland, Oregon. I'd like to thank the organizers of this session for inviting me to share with you some data on elexacaftor, tezacaftor, and ivacaftor, or ETI, in pregnancy. I appreciate not only the organizers' invitation, but also their and your flexibility and commitment to this conference and community to make NACFC a rich and valuable experience for us all, even with the Delta surge. I'm going to spend a few minutes sharing some data which I hope will pique your interest in an important question in both the adult and pediatric worlds, and that is the fetal and infant exposure of ETI in women with CF who are either pregnant or breastfeeding. In addition, I hope this serves as a bit of a preview of some of the important work that is being supported by the CF Foundation in a major therapeutic development network trial, which is just getting started. These are my disclosures, which are pertinent only for being a site PI of a clinical trial for an next-in-class CFTR modulator from Vertex. By way of background, reproductive health has been an increasingly important part of CF care over the last few years. Or perhaps it's more accurate to say that it's always been important, but rather this importance is being increasingly recognized. Tracy Kazmersky and colleagues performed a thorough study of behavior surrounding sexual and reproductive health in women with CF in 2017, which showed the majority of young women with CF desired pregnancy at some point in their lives. That study was conducted in 2015 and 2016, which feels like a lifetime ago given how much the CF landscape has changed in recent years. And one may reasonably imagine that with greater opportunity for most people with CF to live fuller, healthier lives, attitudes towards reproduction may have evolved further still. Indeed, data from the CFF patient registry has shown that the number of pregnancies in women with CF over the past 20 years has more than doubled, with much of the observed increase taking place between 2014 and 2019, which we could think of as the early era of modulators before the modern era of highly effective modulators available for most people with CF. I believe we could all easily imagine that this figure will no doubt have increased further still in the 2020 annual report. This is because not only has availability of highly effective modulators for most people with CF improved metrics such as lung function, nutritional outcomes, and quality of life, it has specifically been observed to improve subfertility in women with CF. This has been formally reported in a series by O'Connor and colleagues and alluded to in other reports, but I believe most of us involved in the clinical care of adults can attest to this anecdotally. Even the CF social media world blossomed with the great 2020 CF baby boom. However, this has raised an important question that many of us have wrestled with in the clinic. Should modulators be continued during pregnancy? What about breastfeeding? This has been a point of discussion for a few years in venues such as NACFC and has been highlighted as a research priority for the CF community, both by providers and for patients. While the consensus has been that providers should have an individual risk-benefit analysis and discussion with their patients, it has been particularly difficult to weigh the known benefits of ETI therapy for women with CF against the largely unknown risks of continuing during pregnancy. Even further complicating the situation is the potential risk for discontinuing treatment with highly effective modulator therapy and what has been dubbed ivacaftor withdrawal syndrome. Scott Donaldson and I reported on this a few years ago in a series of individuals with a G551D mutation who suffered clinical decline following sudden cessation of ivacaftor, and since then, a few similar reports have also been described. A great deal has been written about the consideration of highly effective modulators in pregnancy in the last few years, highlighting many different important and particular considerations beyond the scope of what I can cover today. But suffice it to say that much is unknown about the use of ETI during pregnancy and breastfeeding, and these are tricky risk-benefit discussions to have, although it appears that the majority of the time, women elect to remain on drug during their pregnancy. Much of what we know so far is from a retrospective case series, which was compiled and published earlier this year by Jennifer Taylor-Kauser and Raksha Jain. In this series, 47 pregnancies with some ETI exposure were followed, more than half of which remained on ETI for the duration of their pregnancy. I'd encourage you to review their publication in the Journal of CF, as there are some important details there. However, no complications deemed related to ETI were noted in infants born to mothers taking ETI during pregnancy, and only one maternal complication was noted as likely related to ETI use, and that was in a patient at our center who developed cholecystitis shortly after starting ETI, which also coincided with the beginning of her pregnancy. So that brings us to the simple but rather important question I'd like to try to answer today. Are infants born to mothers taking ETI exposed to drug in utero and while breastfeeding? Previously, we reported on a mother and infant pair who remained on lumacaftor and ivacaftor during pregnancy, with high levels of drug observed in cord blood, as well as lower levels observed in infant blood and breast milk out to around 180 days of life. For the present study, we conducted an observational study to measure the concentrations of elexacaftor, tezacaftor, and ivacaftor from maternal plasma, cord blood, breast milk, and infant blood, all in a very similar fashion to the prior study with lumacaftor and ivacaftor. This study was approved by our local IRB, and we enrolled women with CF who are pregnant and elected to remain on ETI during their pregnancy, and who also provided their informed consent. We collected samples at the time points shown here. Because this was an observational only study, we did not have specified time points before or after birth from which or when we were supposed to draw samples, with sample collection meant to coincide with clinical sample collection, particularly for infants. For this study, we partnered with pediatric providers for the infants who were being followed with liver function tests during the early life because of the risk of ETI exposure from breast milk. And we collected additional samples of plasma, of maternal plasma, along with breast milk whenever possible. We did not control for the timing of ETI doses. Samples were then sent to the lab of Chuck Esther at UNC Chapel Hill for concentration analysis, and he achieved this by LC mass spec using methods used in the previous study, as well as other work he has done in the metabolomics of various CFTR modulators. Because this was intended to be a very small study enrolling just a few patients, and because the assay used to determine modulator concentrations is not an FDA-approved laboratory-developed diagnostic test, our IRB did not wish for any individual data to be reported or disclosed to anyone outside of study personnel to avoid influencing clinical decisions on either maternal or infant care. Thus, all data reported will be reported in aggregate without the use of any statistical tests. At our center, we enrolled 2 women with CF, both of whom were homozygous for F508del. One woman, who had the cholecystitis I mentioned earlier, conceived shortly after starting ETI after attempting pregnancy for some time. Another woman was enrolled during the second trimester when ETI became commercially available. A third mother-infant pair was enrolled at Upstate in Syracuse after the woman delivered and the infant was diagnosed with cystic fibrosis despite a negative newborn screen. This case has been previously reported by Chris Fortner and was a fascinating subject of one of the cases presented and discussed this year here at NACFC in Physician Grand Rounds. Here are the aggregate maternal concentrations of drug over time. And you can see here that in the perinatal period, there appeared to be a decline in all 3 components of ETI. I should note that all the figures I will show you are plotted in a log scale. Here we have the relative concentrations of maternal plasma, cord blood, and infant plasma obtained around 24 hours of life for both ivacaftor, tezacaftor, and elexacaftor. Similar to the prior study of lumacaftor and ivacaftor, there appeared to be elevated or similar levels of all 3 components seen in cord blood compared to maternal plasma, with 24-hour infant levels beginning to decline just slightly. We did identify all 3 components in breast milk out to over 3 months of life. And lastly, we did identify all 3 compounds in infant plasma out to over 3 months of life. It is worth noting that these levels are a few orders of magnitude lower than the maternal levels we're seeing, and that tezacaftor, here in the yellow, appeared to be higher relative to ivacaftor and elexacaftor. Additionally, one sample here did not have elexacaftor detectable below the lower, above the lower threshold of detection. And because these are plotted on a log scale, this can't be plotted here as a 0. Lastly, I wish to share some of the clinical data from the infant with CF included in the study, shared with me by Chris Fortner, who is a co-author on this abstract. This was not included in the published case report earlier this year, but likely will be covered in physician grand rounds. But bear in mind, I'm recording this in September and haven't yet seen that. One of the remarkable features of this case was the normal pancreatic function, which itself led to a false negative newborn screen. An early concern was that, in part based on the previous work with lumacaftor, ivacaftor, the infant levels of ETI would be low, likely below whatever threshold of CFTR rescue is sufficient to maintain pancreatic function. So the infant underwent serial fecal elastase measurements, which are shown here, with the normal range being above 200 and the upper limit of detection being 500 micrograms per grams. Thus, the patient did remain pancreatic sufficient up to 1 year of life. A serum amylase and lipase were checked after this low level of fecal elastase, although the infant did not have any signs or symptoms of pancreatitis. And it was notable for a normal amylase, but a surprisingly elevated lipase. So, to conclude, our small study provides further evidence that fetal exposure to ETI during pregnancy appears to be within the therapeutic range, although appears to begin to be metabolized early in the neonatal period. This is consistent with the prior study of lumacaftor and ivacaftor. Additionally, there does appear to be a drop in maternal plasma concentrations in the perinatal period. This is likely due to the complicated pharmacokinetics of CFTR modulators, which are highly protein bound and are present in the intracellular space at much higher concentrations compared to plasma, and these have been very difficult to quantify. Furthermore, since the compounds act within the cellular compartment, the significance of variations within the plasma compartment are really difficult to assess. Additionally, we did see variable, but generally detectable concentrations in infant plasma out to 3 months. There was one sample for which elexacaftor was below the level of detection, and however, tezacaftor appeared to most easily pass into infant plasma, or at least was the most resistant to infant metabolism, as it was present at the highest concentrations relative to the other components. And again, it is worth noting that these values, even for tezacaftor, are a few orders of magnitude below the maternal levels and are unlikely to be within its therapeutic range. Lastly, I hope that a great deal of light will be shed on this subject in the coming years as a result of the Mayflower study, which is getting started and being overseen by Raksha Jain and Jennifer Taylor-Kauser, both of whom have been very active within the world of women's health and CF, particularly surrounding the effects of modulator use on reproductive health. This is a prospective observational multi-year study that plans to recruit from dozens of care centers, and it does include a sub-study on the pharmacokinetics of modulators. So hopefully in the years ahead, we will be able to provide better and more informed care surrounding reproductive health in women with CF. Thank you very much for your attention. And again, I wish to thank the organizers of this session for their invitation to talk, as well as to the women and families involved in this study, and my collaborators, Chuck Ester at UNC and Chris Fortner at Upstate, and also to the staff of the local care facilities that help with specimen collection. I believe we are switching to a live session now, and I'm happy to answer any questions. Thank you very much.
Welcome back, everyone. That was a very, very interesting session. Thank you so much for that, Dr. Trimble. We're so happy to have you here, and we have some good questions lined up and some good discussions. So let's go ahead and jump right in.
Great.
All right. So our first question for you is, based on this exposure demonstrated, what monitoring would you recommend for infants born to women taking Tricopter during a pregnancy and breastfeeding?
Yeah, thank you. Certainly, I think with a study this small, it's hard to make really any recommendations from this. But maybe the first thing is actually from really Chris's case, is that women or infants born to women with CF, if their partner has not been tested for CF or to be a carrier for CF, that they haven't had any genetic testing, I would not rely on a newborn screen to assess whether or not that infant has CF or not, as the carrier frequency for CF is relatively common, really, in all ethnicities, as has been mentioned over and over again. CF is not just disease of white people, and that I would, if the carrier status is not known of the partner, that infant should have genetic testing done. Secondly, and I didn't get into this, is cataract formation has been discussed. Certainly those in the pediatric space are well aware of that, and the testing for children with CF who are taking ivacaftor and getting eye exams. So I think it's really important that infants born to women taking any modulator containing ivacaftor undergo formal ophthalmologic evaluation. As far as other monitoring beyond that, we haven't, again, this is too small to say, but certainly with the other cases that have been mentioned at physician grand rounds about liver dysfunction and liver failure with modulator exposure, I think at least getting liver function tests is important.
Yeah, thank you for that. That is interesting. Question number 2. This data is fascinating, particularly in the context of the infant described in physician grand rounds. Could you speak to what you think this means for newborn screening in this unique patient population with the potential for false negatives, which you already addressed, I think, but.
Yeah, no, just to absolutely note that infants should be tested, and also to be familiar with the fact that, or familiar at least with how a partner was tested. If a female partner was tested for as carrier status, what was tested? If it was like a really small 8 or 16 mutation panel, that may not be sufficient to detect other mutations that are present in that. I counsel my patients who are pregnant, even if their husband has been, or if their partner has been screened, to know that there's still a chance that their infant may have CF, and that it's unlikely, or it may not be detected from a newborn screen.
Okay. So I have another question for you, or just a thought, or a piece for discussion. I found it interesting that the tezacaftor levels were higher than elexacaftor and ivacaftor. Any hypotheses or any thoughts about that?
Yeah, no, I'm not. I felt like a fish out of water in this session. I'm a physician, not a pharmacist. So using terminology regarding metabolism, I have no idea what you're talking about. To be honest, I don't know. I'm not real familiar with the metabolomics of the 3 different compounds and what may or may not be different about them. Certainly in an infant liver and an infant to metabolize those. So I don't know. Do you have any thoughts?
Yeah, I don't know. I would think, and I would go back to the molecule size of the tezacaftor and those, and see if that makes a difference. And then I also wonder as well. So we know that the liver metabolism pathway of the infants is not fully developed at all, right? So I wonder how much of a factor that plays into that as well. So
yeah,
I don't know either.
Actually, a point about that is that and this was actually noted in the previous study as well, how quickly knowing that the infant liver is not the same as an adult liver, which I'm an adult provider, so I've absolutely been learning a lot with this, that the levels of the compounds fell from cord blood to 24 hours of life. And that was actually really surprising, that there seemed to be at least some level of metabolism occurring right away as exposure dropped just during those 24 hours.
Yeah, yeah. Okay. A new question has come in. When you are talking to your patients, how do you describe the potential risk and benefits for staying on modulator therapy during pregnancy, given this is still early in data?
Yeah, great question. As most of us are, I'm sort of affected more by my own personal experience than by things that we read, for better and for worse. Certainly there's been highlighted need for this data, and the case series that had been published by Raksha and Jen Taylor-Kauser had was helpful, but that's still very small. And actually, just after I had recorded this and that talk, and very recently in our own center, we had a patient who had a very late pregnancy loss at 38 weeks. It was very sudden, without any signs of that there had been any issues with the pregnancy up until that point. It was just heartbreaking. And that was in a patient whose husband is a known F508del carrier. And unfortunately, we don't know if that infant had CF or was a F508del homozygote, 50-50 chance of that. So that has, just is no doubt shaping my own, just a, horrible experience with that patient, is shaping my own caution. Certainly that may be unrelated, as is always the case, you just don't know. Yeah, it's really, really hard to assess risk. There's certainly been tons of pregnancies that have occurred with these modulators without clear danger, or at least ill effects that have been noted or reported on. So it seems that as more time goes on, and there's we have a growing degree of confidence about the use of these drugs in pregnancy, but still caution should be urged. And with events like the one we just had at our center, I think need to be reported both to Vertex and into the community for so that we can pool our collective experience.
Yeah, I'm so sorry to hear about that with your patient, but I agree. So we have time for one more question. It looks like, given the discussion about infant CYP metabolism, how long do you think the monitoring should be done in the infant? For 3 months, for longer? Any idea?
So yeah, again, I'm not a pediatrician, so it's hard for me to make a recommendation, but just from my own familiarity with these data, and I would say as long as the infant is breastfeeding, but again, deferring to the expertise of the pediatrician who's caring for the infant.
Okay. Well, thank you so much, Dr. Trimble. We are I'm really looking forward to more data on pregnancy and infants, and with these highly effective modulator therapies, which are going to be here to stay. So we got to learn about what's going on, and how to best manage it, and to guide and direct our patients. So thank you so much for your time and for your insight. Really appreciate it.
Thank you.
All right, and then we are going to transition over to our final session for today. This is going to be on the impact of the pharmacy technician on CFTR modulator eye exam monitoring. And our presenter for this session will be our very own Dr. Rebecca Pettit, who is a pediatric pulmonary clinical pharmacist at the Riley Hospital for Children, Indiana University Health. So we're going to watch this last video. We'll come back for questions and discussion, and then we'll be done for the day. So we'll see you guys in a few minutes.
Hello, my name is Rebecca Pettit, and I'm the Pediatric Pulmonary Clinical Pharmacist at Riley Children's Hospital at IU Health in Indianapolis, Indiana. And today I'm going to talk to you about our quality improvement project titled The Impact of the Pharmacy Technician on CFTR Modulator Eye Exam Monitoring. I have nothing to disclose in relationship to this presentation. So as you probably know, CFTR modulators have the potential side effect of cataracts. Due to this side effect in pediatric patients, the package insert recommends for cataract monitoring or screening. The package insert doesn't recommend a specific time period for the monitoring. However, at our center at Riley, we do recommend a baseline eye exam to screen for cataracts and then a yearly eye exam while on a CFTR modulator. We knew at our center that we weren't doing a great job of getting our patients to get their eye exams and then also getting those eye exam reports and having it documented in the EMR. However, when we had one of my pharmacy students actually look at our data and update our lists, we found that in January of 2020, we only had 35.5% of our patients on CFTR modulators that had an up-to-date yearly eye exam. This was 64 of our 178 patients. So you can note this date, it is before the pandemic, so we don't really have to factor in any of those pandemic-related barriers to eye exams for this number, and unfortunately it's still pretty low, and we felt like as a center that we could definitely do a better job of following up and also getting our patients to get those eye exams regularly. So the objective of our multidisciplinary quality improvement project was to improve our compliance with the yearly eye exams for patients on CFTR modulators to greater than 50%. We felt like 50% was a reasonable goal. We didn't want to shoot too high since we were only at 35.5%. And also at the beginning of our project, we were dealing with the effects of the COVID-19 pandemic as well. So we felt like this was a reasonable goal to shoot for. Our multidisciplinary quality improvement project group consisted of myself as a pharmacist, my two wonderful pharmacy technicians, the nurses in the clinic, as well as the CF clinic coordinator, as well as physicians for input as well. We used the Plan, Do, Study, Act, or Pdsa Cycles for our project. Our first PDSA began in February of 2020 and went until June of 2020. During this PDSA, what we implemented was relatively simple. So we had myself as the clinical pharmacist screen the patients during pre-clinic review to determine if they were due for an eye exam. And then during clinic, them nurses and MAs would remind the patients that I identified that they were due for an eye exam. If I saw them myself in clinic, I would also remind them as well. So really simple, and we wanted to start out simple, especially given this time period and the constraints of COVID during this time period. So you can see the results we got from this first PDSA is by March, we were up to that 50% range, which was our goal. However, by July, we were back down to where we originally started. Could have been many different factors, including the effects of the pandemic on eye exam availability, as well as patients' willingness to get eye exams. However, we felt like we could do better and have a more consistent follow-up with our patients to help improve these numbers. So this led us to our PDSA cycle number 2. So in this cycle, we developed an eye exam standard of work, and we really worked to make the pharmacy technicians the drivers of this workflow. And that was different than we were doing previously in the PDSA 1. You saw that myself as a pharmacist was the driver, as well as the nurses. But this kind of change the face and put it on the pharmacy technicians to help with that follow-up. So I had a wonderful PGY2 pharmacy resident, Taylor Ambrusia, who was with me last year and helped create this eye exam standard of work along with the pharmacy technicians and the nurses to really incorporate all the different voices to the standardized process to help ensure its success. We utilize the Theragy system that our specialty pharmacy uses to help with follow-up on the different tasks. This standardized workflow was implemented for the pharmacy technicians in November of 2020. Along with this, I continue to do those pre-clinic screenings, but we did change this to help improve this in Pdsa cycle number 2. And we created just a paper flow sheet that in preclinic screening, I write the names of the patients that are due for eye exams, either reminders or are due already. It prompts the nurses and MAs to ask the patient why they're in clinic and provides them a space to document real time if they just reminded the patients, or maybe the patient said they had an eye exam scheduled. It prompts them to write down where and when that eye exam is going to be, so we can ensure we follow up after that exam to get those results. This has really helped with our documentation of those reminders in clinic and making sure we have that documentation on the back end and in a consistent place. So this really has been beneficial to the clinic flow and that process in clinic. So I want to walk you through our standard of work that was created for our pharmacy technicians and what is done with each of the patient scenarios. So it begins with the patient being started on a CFTR modulator. When that happens, the pharmacy technician fires a task in the Theragy system, the eye exam task, to track the results of this. And then it depends if the eye exam has been completed or not. If the eye exam has been completed, then the pharmacy technician reaches out to the eye doctor's office where that exam was completed and requests a fax of the eye exam result. They contact the eye doctor weekly to obtain that result until it's obtained. Once they receive the eye exam result, they load that into our EMR in a consistent place that all the team members know where, and it's labeled correctly. And then they complete that Theragy task and set the follow-up to fire from 1 year from when the eye exam was done. If the eye exam was not completed, this is where it gets a little more complicated. So the technician will reach out and contact the family, and a few different things could happen. When they call family, if the family answers, they may have already had the eye exam. So the pharmacy technician asks where and when the eye exam was done, and then contacts the eye doctor's office to request that result, and then contacts them weekly until they get it. And just like the other process with the completed eye exams, they load that into the EMR once they receive that and complete that task in Theragy to launch the appropriate follow-up. What can also happen is that the family doesn't answer the phone calls. So if the family doesn't answer the phone call, then the technician will set the task out 2 weeks from that call date. And then the technician will call 3 times. After 3 failed attempts, they will document in the EMR and notify myself, the nurses, and the physician that they have been unsuccessful in reaching the family for the eye exam results, and that proactive follow-up will be discontinued. They also recommend that the clinic team follows up in clinic, and then we set the clinic, the eye exam task follow-up date to the next follow-up clinic so that we can follow up with them in person. Another thing that can happen is that the family will answer the call, but they have not completed the eye exam. If this happens, we do remind them and encourage them to get the eye exam result appointment scheduled and to let us know once that is scheduled. And then we set the reminder out 1 month from that phone call to check on the patient's progress. That being said, if at any point in time in this process, patient notifies us that they have an eye exam scheduled, we try to get where and when, and then we set the follow-up to after that exam has happened, so that we can reach out to the eye doctor to get that report. So you can see here that when we implemented the standard of work in November of 2020, we were already back up to that 50% range, which was great. However, this standard of work and having the pharmacy technician as the driver of this process has really allowed us to have some sustained improvement over time. You can see there we had that steady increase up to our highest amount in June of 2021, which was 87.4% of our patients. So 167 of our 191 patients. You can see there, that was before the numbers before elexacaftor, tezacaftor, ivacaftor was approved in the 6 to 11-year-olds. So this added more patients to our load, but you can see there we did pretty well. So we had a slight decrease, but have been uptrending. So our last numbers in September of 2021, we had 85.7% of our patients, so 180 out of 210 total patients. So really sustained improvement over time, which I think is a testament to the success of this process. So in conclusion, our project shows sustained increase in compliance with yearly eye exams in our pediatric CFTR modulator patients after we put the pharmacy technician really at the driver of the process and developed that and implemented that standard of work and documentation process. This really is a multidisciplinary undertaking from myself as a pharmacist, the pharmacy technicians, nurses, MAs and clinics, as well as the physicians who also remind them, their patients, of the need for eye exams as well. So I'd like to acknowledge Tiffany Burris, one of my pharmacy technicians who played a large role in this project, Lindsay Hagee, Taylor Ambrusia, Erin Newbill, our CF coordinator, Shauna Palmar, one of our clinic nurses, and Laura Burkart, our other clinic nurse, for all their help in this process. I'd also like to thank all of our patients and their families for actually going to the eye doctor and get their eye exams done. We couldn't do it if they didn't actually go to those appointments. So thank you so much for listening to this presentation. If you have any questions, feel free to shout out at me during the meeting. If you have any questions afterwards, I have put my email address on the slide there. So please definitely shoot me an email if you have questions as well. Thanks.
Welcome back, everyone. That was a great presentation. It really just energized me because teamwork is at my heart. And I think this was a great example of a QI project that incorporated everyone. I want to shout out my pharmacy technicians. Fantastic. I couldn't do what I do without them. And I know that our technicians are integral to all that we do. So I love this project, and I love the integration, and my tagline or slogan is teamwork makes the dream work, and this was a great example of that. So we're here with Rebecca. Thank you for all of your work here, and we have lots of questions. Let's go ahead and jump right on in. So the first one for you, Rebecca, is how many pediatric patients at your center have developed cataracts?
That's a great question. So right now we have a little over 200 pediatric patients at our center, so less than 18 that are on modulators. Luckily, we've only seen a handful, I'd say a couple that have had cataracts noted. Actually, some had them on their baseline exam and were thought to be congenital. And then we've also had some patients that have had cataracts identified, but they've also had significant steroid exposure in the past. So it's been difficult to say, is it the modulator or is it some other drug that is potentially causing that?
Okay. All right. Next question for you. Are all of your patients enrolled in your specialty pharmacy program and therapy, or is this a subset of your patients?
Great question. So not all of our patients, unfortunately, can fill at our specialty pharmacy. However, our pharmacy technicians work on all of the prior authorizations for the patients, regardless of where they fill, and they use Therapy as the driver of their workflow. So they are all loaded into the system, which allows us to do the eye exam tasks in Therapy, regardless of whether they can fill their modulator at our pharmacy or not.
That is awesome. I love that. For all the patients, that's great. For the eye, next question, for the eye exam review, is it verified that slit lamp exam was done? In this example, we have encountered situations where patient had an exam, but upon a detailed review, it was not the right type of eye exam.
Yeah, so that is something that we have run into as well. I look at all the reports that come in and the physicians get notified them as well, but we do look for comments from the eye doctor. We do make sure they are done by an ophthalmologist or an optometrist that actually does comment on the lens and if it's clear or not, and try our best to make that assessment. Granted, our center sees patients from all over Indiana, so there's definitely going to be variability there on the quality of exams, but we do our best to try to make sure the eye doctor is actually looking at the lenses and assessing them.
Sure. And I have a follow-up to that as well, actually. How would you rate your success rate of getting the ophthalmologist to actually fax you the notes back? Because I saw that was like a thing on there to follow. I was like, how frequently is that happening or not happening? Like, is it a challenge?
You would think that would be the easiest part of the process, but a lot of times it's not. We ran into some that want releases of information or who, despite calling every single week, aren't faxing it. So we are kind of persistent, and eventually I or the technicians, I tell them, start saying you called like 3 times, like someone needs to fax this, needs to figure out how to get it. And then, if we're still unsuccessful, sometimes I'll get the families on the line and try to call together and see if we can be successful in that way as well.
That's a lot of work. It's a lot of work and a lot of time. Next, a question for you. Did you utilize the Vertex 2020 on-site mobile eye exams as part of this QI project?
Yeah, so that was definitely an option. They have come formally once for our patients. They set up a date and came. Unfortunately, only 2 of our patients actually took advantage of that program, which was kind of sad, but at least those 2 got it in. So I didn't factor it in as much of an impact on the results, but we do offer that as an option for patients, which I think is helpful. But most of our patients have decided to either go locally or come to Riley Ophthalmology for their exams.
Okay. And then I have another one here in the queue for you. Can you comment on the time expenditure for yourself and your technician or technicians, and if that has changed as families are more familiar with the annual expectation?
Yeah, so I would say from the technician standpoint, and like the follow-up phone calls, it's usually a couple hours per week. We do have a large patient population, so that and it varies depending on obviously once we got up to that 80%, it's been easier and less time consuming to maintain because they're kind of getting used to that expectation. And actually, since we've been able to get up that high, my clinic review process has gone down significantly. And I've started looking out like who has an eye exam due in the next 3 months. Like, let's be a reminder in clinic instead of you're overdue. Let's try to remind them as many times as possible. So we've tried to incorporate that to hopefully get patients thinking of it and get them actually scheduled for that.
That's a great shift. Yeah, I really like that. I'm really encouraged by that, and hopefully different centers across the country can also take that and run with it. So
yeah.
Awesome. Well, I think that's the end of our questions. And I think that we're 6 minutes over our 1 o'clock end time. There was one that we missed though, and I'm glad that Dr. Trimble is still here. I do want to go ahead and throw this out there if I can, because it was asked and I missed it before we had shifted over. But for you, Dr. Trimble, it was given the potential for ivacaftor withdrawal, how do you go about discontinuing Eti therapy when patients want to?
Yeah, great question. And it's been interesting. The number of patients on highly effective modulators has certainly substantially increased in the last 3 years. And I certainly have my ear to the ground for patients who have really severe withdrawal, and have noticed in my own practice a little bit, but haven't seen widespread cases of withdrawal from highly effective modulators like one might have predicted. To be short, and being respectful of time, don't have a real clear methodology that we follow, but I don't think it needs to be a prolonged, taper down, but just dose reduction over a period of frankly, a week is likely to be sufficient. And in fact, it may be that just the longer half-lives of TEZ and Elex are sufficient enough to mitigate the effects of highly effective modulator withdrawal compared to IVA alone, which has a much shorter half-life.
Okay, thank you for that. It seems that we answered all the questions, and we're at the end of our session. Thank you all so much for your time and your insight. And I want to also extend a special thank you to Cameron, my co-chair. She did an amazing job with the questions and working with Slido, and she's just been amazing all the way through and through. Thank you to the CF Foundation, and hope to see you guys next year, but we're signing out.